for Dr. Daniel Mack. He is an assistant professor of pediatrics at Arkansas Children's Hospital, and he is going to be talking to us about updates in diagnosis and treatment of delayed puberty. Thank you, Daniel.
Thanks, Dr. Shona. Let's see. Cool. Is it shown? I think so.
Yeah, we got it. You're good to go.
Awesome. Thank you. Thanks, Dr. Shona, for the introduction. And thank you, everyone, and all the organizers for Pistola. I'm really excited to be part of it. And a special thank you to Dr. John Oden for putting my name forward to give this talk. I'm truly honored. So this talk, we'll be talking about updates in the diagnosis and treatment of delayed puberty. I have no disclosures. So let's get into it. So we'll be talking about the differential diagnosis of delayed puberty, as well as discuss the evaluation of a patient with delayed puberty, and then also explore the approaches and new approaches in differentiating constitutional delay of growth in puberty and idiopathic hypogonadism, hypergonadotropic hypogonadism. So first, a definition of delayed puberty. So this is the other spectrum of puberty, as opposed to Dr. Silverman's precocious puberty. So delayed puberty is, as you know, the absence of physical signs of puberty beyond the normal range for the population. So generally that's 2 to 2.5 standard deviations above the mean. In the US, it's a lack of breast development by the age of 12 or 13 years old for females, and a lack of testicular enlargement for boys by the age of 13 to 14 years old. And stalled puberty is puberty that hasn't been completed within starting approximately 4 years of onset. So we know that there's great variation in the timing of puberty, and we know that genetic and environmental factors do influence the timing of puberty. So much so, about 50 to 80% of the variation in pubertal onset can be linked to genetic factors. So it was shown in twin studies that monozygotic twins compared to dizygotic twins had a greater concordance with the timing of puberty. And specifically in girls, it was the timing of menarche. We also know that there's clear racial and ethnic variations in the onset of puberty. And this was shown in one of the landmark studies that looked at puberty in females across the country. And it found that earlier onset of puberty in African-American girls compared to Caucasian counterparts. So in talking about the etiology or the causes of delayed puberty, we can classify it based on the circulating levels of gonadotropins. So in hypergonadotropic hypogonadism or primary hypogonadism, you have elevated gonadotropins and low sex hormones. Whereas in secondary hypogonadism or hypogonadotropic hypogonadism, you have low gonadotropins and low sex hormones. Another condition that we're not going to talk about in this talk, but can also present or mimic delayed puberty is androgen insensitivity syndrome, specifically complete androgen insensitivity syndrome, where you have elevated gonadotropins and elevated sex hormones. So what are the common causes of delayed puberty, and what are the frequency of these conditions? So in a large cohort study from Boston Children's from 2000-2015, they looked at all the patients that presented with complaint of delayed puberty. And first you'll notice that there's a significantly greater amount of males that present compared to females, almost double that. And of the different diagnoses, females were more prevalent to have primary hypogonadism. Within the category of secondary hypogonadism, constitutional delay of growth in puberty is the most common cause, with the overwhelming majority in males at 70%. There's other causes of secondary hypogonadism, including functional hypogonadism, which we'll talk about, chronic illness, hypothalamic pituitary disease, And then when we're talking about true isolated or idiopathic hypogonadotropic hypogonadism, it accounts for actually a small percentage, with that being 2% in males and about 0.5% in females. So primary hypogonadism. So this is also hypergonadotropic hypogonadism. So what are the different causes of that? We know chromosomal disorders like Turner syndrome, Klinefelter syndrome, multiple X syndrome. There's also autoimmune polyglandular syndrome. And then interesting, galactosemia. So about half the females with galactosemia will end up having hypogonadism, and it's thought to be due to toxicity of galactose metabolites resulting in atresia of the primary follicles. There's also testicular regression syndrome or vanishing testes. Radiation and chemotherapy are known causes of primary gonadal failure. And for chemotherapy specifically, alkylating agents like cyclophosphamide and cisplatin can be causes. And finally, infections. Causes for secondary hypogonadism, which is again hypogonadotropic hypogonadism. You can have GnRH deficiency, which is also called isolated or idiopathic or congenital GnRH deficiency. You have normosmic, hyposmic, or anosmic variations of it, with anosmia being classically called Kalman syndrome. You have constitutional delay of growth and puberty, like we talked about. Functional causes of hypogonadism include anorexia or low BMI, hypothalamic or pituitary disease such as suprasellar masses or craniopharyngioma, chronic illness including hypothyroidism, lupus, IBD, or other systemic causes that may lead to secondary hypogonadism. So when looking at the evaluation for someone with delayed puberty, first we're looking at the history and physical exam. So history, are there any pertinent parts that can indicate one of the differential diagnosis that we talked about? So are there any systemic underlying conditions that are present? Is there any history of chemotherapy or radiation therapy? Is there a family history of delayed puberty that may be important to this patient? In terms of physical exam, doing a pubertal exam or specifically breast exam for females and testicular exam for males using a praetor-orchiometer to measure testicular volume, because we know that oftentimes we all refer patients who have supposedly delayed puberty, but actually on physical exam, we find that they actually have started puberty, but maybe their perception is different than what they were expecting, or maybe it's different from their peers. So it's always important to do the physical exam to determine whether or not they truly have puberty or not. So let's say we have a patient with delayed puberty, then how do you work them up? So you have general screening labs like CBC, CMP, whatnot, and other labs that may point towards some underlying systemic cause, celiac panel. But then when you're looking at hormonal causes, of course, we're going to get gonadotropins, LH, FSH, sex hormones, testosterone, estradiol, and then again, thyroid function tests, growth factors, and bone age would be important. So growth factors will be important because it may point towards other multiple pituitary hormone deficits, which may be contributing to delayed growth. So when we have our gonadotropins and we're looking at the circulating levels, are they high? And then we're thinking hypergonadotropic hypogonadism, like we talked about, or are they low or normal? And then we're looking at, well, if they're below the prepubertal growth rate, then are we suspecting some functional cause of hypogonadism? Is there chronic disease, or do they have multiple pituitary hormone deficits that we have to look into as well that may be affecting growth rate as well? Let's say they have normal prepubertal growth rate, then we're thinking about GnRH deficiency or constitutional delay of growth in puberty. So this is going to be the meat of the talk, really differentiating constitutional delay of growth in puberty and idiopathic or isolated congenital hypogonadotropic hypogonadism, because this is really the diagnostic dilemma when it comes down to this point, because how do we differentiate the two of them? And there's no single test that's reliably able to distinguish the two of the etiologies. And the gold standard really is just serial observation over time. And then with the presence of pubertal development by 18 years old, indicating constitutional delay of growth in puberty. So just like the cohort from Boston, what are the sex differences in presentation? Well, from multiple studies and surveys, it looks like boys are more likely to present for evaluation of delayed puberty than girls. In one survey of pediatric endocrine providers, again from the Boston group, there were 184 respondents, and it found that there was a wide range in kind of the treatment strategy for patients with delayed puberty. Some providers are willing to start sex steroid treatment in both boys and girls as young as 13 years old or even younger, whereas others were reluctant to start treatment in patients even as old as 15 years old. From this survey, it was found that providers on average did tend to wait longer to treat girls than boys. This figure here shows the ages at which providers were treating patients with sex steroids. So again, at a given age or different range, on average, boys were more likely to be treated earlier than girls. And specifically, when they looked at it, providers would initiate treatment with sex steroids at a mean age of 14.3 plus or minus 0.7 years for boys and 13.6 plus or minus 0.9 years for girls. For the boys, 55% of providers would start treatment by the age of 14 years old, and 99% would start treatment by 16 years old, whereas for girls, 42% would start treatment by 13 years old, and 95% would start by 15 years old. So what are the reasons or some of the rationales for starting treatment for these patients? So interestingly, for females, one of the significant findings was that the decision to start treatment for females was due to bone mineral density concerns, whereas for boys, some of the primary reasons for starting sex steroid treatment earlier was due to patient distress, as well as parental distress and growth concerns, as well as really the desire to jumpstart puberty. So are there points in the clinical history that may lead one versus the other in terms of constitutional delay versus hypogonadotropic hypogonadism? And we have seen that family history of delayed puberty is a major factor, but it actually has also been found in families with isolated hypogonadotropic hypogonadism as well. Well, patients with constitutional delay, they're more likely to have also delayed adrenarche, whereas individuals with IHH are more likely to have just delayed gonadal development alone. There's also features of anosmia or hyposmia, which are features of Kallmann syndrome. But again, it's only about 30 to 50% of those with apparent IHH. So what are the challenges of making this diagnosis, or what are the challenges of not making the diagnosis? So the challenges are the inability to make this accurate diagnosis at the initial presentation, or even some subsequent follow-up visits, is that there's difficulty in providing appropriate counseling to the patient and family, what to expect, as well as it can generate anxiety for the patient and families, especially if other peers are developing and this patient is not. And as we've seen, it can actually affect management decisions. So for decades, diagnostic tests have been really sought after to differentiate the two conditions. And in the past, basal gonadotropin levels were thought to potentially have a role, and there was the overnight frequent sampling versus single basal level. And in general, patients with IHH were found to have lower basal gonadotropin levels than those with constitutional delay, but there was considerable overlap. Stimulation with GnRH or GnRH agonists, again, has been looked into. And again, patients with isolated hypogonadotropic hypogonadism have lowered stimulated LH levels compared to other peers with constitutional delay, but again, consider overlap exists. And also, there are multiple different protocols, and some with the best sensitivity have been shown to be the longer protocols. Testing with HCG has been also studied, and there's also multiple protocols and multiple doses that have been published. And some of the best results, again, come from the longest protocols, which may be impractical. And there's also concern for germ cell apoptosis and inflammation. Inhibin B, which is commonly used or evaluated or looked at as a screening tool also, which is a glycoprotein which is secreted by the Sertoli cells in testes or granulosa cells in the ovary. And it's regulated by the feedback inhibition with FSH. So this has been looked at as a possible marker for differentiating the two. So the downsides are studies are mostly in males, but some evidence that this may be a good first-line test. So there's one study by Coutant et al. And colleagues in 2010 that demonstrated a single inhibin B level of 35 picograms per milliliter or less had 93% positive predictive value in identifying patients with IHH from those with constitutional delay of growth and puberty. And this predictive value actually increased to 100% when looking at those patients that were Tanner 1, so with testes less than 3 mLs. They also showed that with Tanner 2 and above, a cutoff of 63 picograms per milliliter may be beneficial. The downside is that other studies have not really replicated this finding, and there's significant overlap in the inhibin B levels. And it's been shown that 10 to 29% of those with constitutional delay and 22 to 45% of those with IHH actually have inhibin B levels that fall within this range of overlap. So we know that other tests are still needed, and to help solve this kind of this diagnostic dilemma of differentiating the two conditions. So enter kisspeptin. So kisspeptin is a neuropeptide and it's secreted by the hypothalamus, and it potently stimulates GnRH in all mammals, including humans. And it's been previously shown by the group in Boston, as well as others, that in reproductively intact adults, they respond to a single bolus of kisspeptin with a robust increase in LH, whereas adults with IHH, they did not respond and did not show an increase in LH. So this has been thought or that it could be potentially used as a provocative testing tool. And Dr. Chan and his group in Boston have shown that their hypothesis was that the child's ability to respond to kisspeptin may lead to some clues into those that will actually progress through puberty and those who wouldn't. So there was a pilot study with 17 children, again, mostly boys, with delayed or stalled puberty. And they showed that a rise in LH of 0.1 milli-international units per ml or greater after kisspeptin stimulation predicted pubertal progression by 18 years of age. So the protocol had two parts to it. The first visit was to get the baseline response to kisspeptin as well as GnRH. And then there's a period of GnRH priming to enhance the response in the second visit. So again, they administer kisspeptin and then also GnRH, and then they watch the results of LH. So in one patient, there was a clear response to Kisspeptin and GnRH with increased LH levels, both in the pre-GnRH priming period as well as the post-GnRH priming period. And then, oops, that's actually, sorry, participant B. And then participant A, they showed that there was no response to Kisspeptin or GnRH. And then after GnRH priming, there was, again, no response to Kisspeptin, but there was a response to GnRH after GnRH priming. So when looking at, again, these individuals, they found that those that did progress through puberty were called the Kisspeptin responders because their change in LH was, again, at least 0.8 and above, compared to those that did not progress through puberty, who all did not have a significant change in Kisspeptin. So Kisspeptin stimulation is a new and innovative way to differentiate between patients with constitutional delay and those with idiopathic hypogonadotropic hypogonadism, but it's not readily available right now. So what other tools do we have? So we know that genetics plays a large role. Could we potentially do genetic testing to find out which ones have specific genetic mutations that are associated with hypogonadotropic hypogonadism? So despite all the understanding and increasing knowledge of the different genes that are playing a role in pubertal timing, still only about less than half of the patients with true IHH have an identifiable mutation in a gene that is responsible for, or known to be responsible for, delayed puberty. So some of the identified genes. So again, there's looking at the isolated hypogonadotropic hypogonadism. There's anosmic, normosmic variations, and anosmia accounts for about 30 to 50% of the cases, with ANOS1 and FGFR1 being the more prevalent genes, accounting for almost about 15% of the cases. When we're looking at the embryology of embryologic development of GnRH secreting neurons, we know that it originates from the olfactory placode, and then they migrate to the hypothalamus, and there are multiple regulating genes that are involved that could potentially play a role in disruption of this process and resulting delayed puberty. When looking at the normosmic variation, the most common is a mutation in the GnRH receptor, accounting for almost 16 to 40% of cases. Interestingly, TAC3 and TACR3 are commonly implicated in normosmic hypogonadotropic hypogonadism, but also have been shown to be present in patients with constitutional delay growth and puberty as well. When looking at other genes, we know that pituitary transcription factors can be affected and lead to multiple pituitary hormone deficits, including PROP1, HESX1, LHX3, and also adrenal hypoplasia can also cause delayed puberty, and also defects in the LH and FSH subunits can also be genetic causes of delayed puberty. So when looking at the treatment for constitutional delay of growth and puberty and isolated hypogonadotropic hypogonadism, what are the treatment strategies? So there's watchful waiting, like we talked about, but a lot of times it's not feasible because of potentially the patient or parental expectations, their kind of the social implications as well, their desire to jumpstart puberty. So there's also hormonal treatment. So what are the goals of hormonal treatment? So the short-term goals can include induction of secondary sexual characteristics, induction of the growth spurt. It is also interesting that has been shown by the group in Finland that there's potential for possible reversal of GnRH deficiency in about 10% of patients with IHH. And this reversibility has been found more frequent in those with the TAC3 and TACR3 mutations. So therapy should be stopped periodically every 3 to 6 months to assess pubertal progression and sex steroid levels. These are the common formulations for testosterone and estrogen. So testosterone, the IM injections have been well studied, and recommendations for starting doses range between 50 to 100 milligrams every 4 weeks for 3 to 6 months. And then afterwards, in those patients that afterwards still do not have sustained gonadotropin and sex steroid levels, then you can continue treatment until you reach adult dosing. Treatment with the transdermal preparations hasn't, it's been extensively reported, but there's no consensus on the dosing strategies or regimens for it. In terms of estrogen, there's multiple different estrogen preparations, including oral and transdermal patches. Transdermal preparations may be preferred to oral preparations as you don't have the liver toxicity that is associated with first pass metabolism. And then also for females that require continued estrogen therapy, then we add on progestin to induce endometrial cycling. So what are other treatments, or are there other treatments that are possible? So growth hormone, we know that in patients that do not have multiple hormone deficits, including growth hormone deficiency, that growth hormone in patients with constitutional delay or IHH may not be beneficial, and actually sex steroid treatment alone will actually help with their growth spurt. GnRH has been looked at as a possible therapeutic option as well. You have to give it in pulsatile doses, and over some treatment protocols have looked at over 10 days, so a little less practical. Use of HCG has also been looked at, and again, has been shown to possibly induce puberty, but again, the protocols or the strategies are a little bit less feasible and require maybe twice weekly injections of HCG over a longer period of time. Aromatase inhibitors have also been looked at as potential other treatment options. So letrozole, an aromatase inhibitor, has been found in boys with constitutional delay of growth and puberty at a dose of 2.5 milligrams once daily for 6 months, has been shown to have significantly higher LH and FSH, testosterone, and inhibin B levels, as well as testicular volume, compared to those that received a low dose testosterone for 6 months. So letrozole has been looked at as a potential therapeutic measure as well. But what are the goals of therapy? So we talked about, again, the short-term goals, or the goals of sex steroid replacement are really to induce virilization, but it doesn't necessarily induce testicular growth or affect fertility for that matter. So this is a little bit outside the scope of this particular talk, but there are several studies that show that treatment with recombinant FSH and HCG actually also lead to an increase in spermatogenesis. That is, I think, another important part of the treatment of delayed puberty, or specifically those with isolated hypogonadotropic hypogonadism. But again, a little bit outside the scope as we're talking about solely kind of diagnosis of delayed puberty. So in summary, so the majority of cases of delayed puberty are due to secondary hypogonadism, with constitutional delay being the most common cause of delayed puberty in both males and females, again, with an overwhelming majority of almost 70% in males. And that's also coupled with the greater proportion of males that are presenting with complaints of delayed puberty versus females. We know that differentiating constitutional delay from isolated or idiopathic hypogonadotropic hypogonadism is a diagnostic challenge. And really, that's been the kind of conundrum that we face as clinicians when we're presented with these patients. How do we tell the families which one it is? And are we going to go the route of potentially watchful waiting? Again, not all families are going to be on board with that. Or do we go with some potential treatment options that may induce or jumpstart puberty, quote unquote? So the use of diagnostic testing has been studied and in the literature, but right now at this time it's not recommended for routine clinical use. Inhibin B may be a good first line use, but again, with a grain of salt because there is quite a bit of overlap. New approaches into investigating the role of kisspeptin is going to be, I think, down the pipeline, and as well as genetic testing, as we're finding more and more genes that are associated with delayed puberty. This may also be a potential tool that we will use in the future. So again, the treatment strategies, or sorry, the diagnostic strategies and challenges, as well as the treatment strategies for managing delayed puberty present a challenge to us, but then also hopefully down the pipeline in the future, we're going to have more tools that may be able to differentiate the two of them and provide better guidance and hopefully relief to our patients and families with greater knowledge. These are my references, and that is it. Thank you so much for your time.
Okay, thank you, Dr. Matt. That's a great presentation, and we do have a few minutes for questions. And oh, okay, we have one question on the chat. Thank you for the talk. Can you talk about the role of HCG? Hold on, how do I put it? Oh, here we go. Can you talk about the role of HCG stimulation test and diagnosis at this point?
Right. So I did look at, thank you for the question. I did look into the literature and the studies that did look at a potential for HCG stimulation testing as a tool in differentiating constitutional delay of growth and puberty and idiopathic hypogonadotropic hypogonadism. Although the results are mixed, again, as you probably aware, there's so many different protocols for using HCG. Not only in diagnosis of delayed puberty. So the protocols are not standardized. And then also in studies that have shown that there was an increase in LH in those with constitutional delay of growth and puberty compared to those with IHH. It's not, again, the ranges have been found to overlap with other studies. So there hasn't been consensus on the best approach or the best protocol. So at this time, it's not used in the diagnosis, just given the wealth of different protocols and strategies and lack of consistent results.
And we have one more question. How long after testosterone priming for 3 to 6 months do you check hormone levels and follow up clinically? Also, if no response with testosterone 50 milligrams, do you increase to 75 for another 3 to 6 months and reassess versus another 50 milligrams for 3 to 6 months?
Yep, that's a good question. So the kind of guidelines or some of the recommendations that have been talked about is reassessing after every 3 to 6 months, because again, in those patients with reversal of IHH, you could potentially stop treatment, and those that continue to have kind of pubertal LH and FSH and testosterone levels afterwards, then they don't need to have continuous exogenous testosterone. But in those patients that do not respond, like you're talking about, the kind of, again, the consensus is not clearly defined, but it does discuss the recommendations potentially, again, monitoring 3 to 6 months. And if by 18 years old that you're still not having any signs of puberty, because that would be, again, the cutoff for constitutional delay of growth and puberty, then potentially we may be looking at another potential underlying cause of hypogonadism. So potentially there is a problem with testosterone receptors or response to testosterone. So we have to look into other potential differential diagnosis if this patient is, one, has IHH, they should respond, or two, has constitutional delay of growth and puberty. And if we're monitoring them serially, and by 18 years old, they still don't have response, then potentially there's some other underlying cause that we should look into. And then again, the incremental changes in testosterone, they vary between 50 to 100 milligrams.
Okay. And briefly, just one more question, and then we'll have to move on to the next speaker. Is the lack of testicular enlargement in response to a testosterone jumpstart reliable in indicating that the patient may have IHH? If so, would you use this exam finding to then guide further genetic testing for causes of IHH?
I think that's a good point, because those patients with constitutional delay, we often do see that they do have testicular enlargement. Interestingly, those with IHH, some have had some testicular enlargement, but in the description in the literature, it hasn't been to the extent or to the level of those with just constitutional delay. So I think it may be a good kind of approach in terms of the diagnostic kind of algorithm, that if you're not having the enlargement in testicular volume that you were expecting, then potentially genetic testing would be a good option